Welcome to TPMG Health Talk. Join us for valuable insights and practical advice on health topics that matter to you most, delivered by our top medical professionals. At Tidewater Physicians Multi-Specialty Group, we're dedicated to providing high-quality, physician-directed care to the Hampton Roads community. Subscribe now and visit mytpmg.com for more resources. Now let's dive into today's episode. On today's episode of TPMG Health Talk, we're joined by Dr. Frances Jones, a board-certified gastroenterologist with TPMG Gastroenterology in Williamsburg. Dr. Jones brings over 20 years of experience, including 2 decades of service in the United States Air Force, where she served as a gastroenterologist and professor at Langley Hospital. She joined TPMG in 2019 and specializes in digestive and liver conditions, including acid reflux, IBD, and IBS. With advanced training in cancer screening and endoscopic procedures, Dr. Jones is known for her thoughtful, patient-centered approach and her commitment to helping people take control of their GI health. We're happy to have you, Dr. Jones.
Thanks for having me. Appreciate the invite.
Yes, welcome. So gastroenterology, I have trouble saying the term sometimes, so if I trip up, I apologize.
When I told my daughter, she would say, I tell people you're a gastroenterologist. And I said, do they know what that is? And she goes, no, Mommy. Sometimes they just look at me funny. And I just tell them butts and guts. And so when she was in elementary school, she goes, my mom's a butt and gut doctor. And they're like, okay.
Butts and guts, I like it. Well, gastrointestinal health may not be top of mind, but it literally affects how we feel every day. If we don't have our butts and guts in order, we actually feel like crap. Dr. Jones, can you kick off things by talking about some of the common chronic GI issues people face and how they can handle them in their everyday lives?
Absolutely. If you can't eat and you can't poop, you are going to be miserable. So some of those more common things are difficulty with eating, difficulty with swallowing. Some people just think they're slow eaters, but they actually have a problem. Another common symptom is acid reflux or heartburn, where they have burning in their chest from acid in their stomach coming up. And then, of course, there's constipation, diarrhea, bloating, and just an overall belly pain.
Are there any conditions like GERD that you see frequently? How do patients typically manage things like that on a day-to-day basis?
Yeah, so GERD and indigestion are typically used by people interchangeably. So GERD, or gastroesophageal reflux disease, is where acid that's supposed to be in your stomach comes up into your esophagus, which is located in your chest. So when that acid comes up, it burns, it hurts. And so you may hear people also use the word heartburn because it feels like their heart is burning, but it's not their heart, it's their esophagus, heartburn. Indigestion is kind of, sometimes more people describe indigestion as just an upset stomach ache feeling with gas, bloat, and some burning as well, which can also be from too much acid in the stomach. So too much acid in the stomach, and then that acid coming up into your chest all create symptoms that are painful.
Now, not all GI symptoms are the same. What are the key signs and symptoms that should prompt someone to seek medical attention rather than managing them on their own? For example, how do we know when difficulty swallowing or reoccurring heartburn might indicate a more serious condition?
Yes. So difficulty swallowing is never normal, and you should just go in and see the doctor.
Oh.
So there can be lots of different things that are happening in the esophagus, and so it needs to be evaluated. It is a red flag symptom. Heartburn intermittently can be treated with many over-the-counter medications or by lifestyle modifications, avoiding trigger foods, adjusting your timing of eating, not eating 3 hours before bedtime, particularly if you have nighttime acid reflux. Once you do those lifestyle modifications, if you're still having persistent acid reflux, you should come in and get treated, because persistent acid reflux over time in some people causes damage to the esophagus, and that over time can lead to cancer of the esophagus. So you don't want to just ignore it.
Wow. That's scary.
It is scary. No one wants esophageal cancer. It's not good. Acid reflux chronically over time can lead to strictures, which are narrowing of the esophagus where food gets stuck, and to esophageal cancer. Particularly nighttime reflux is really pretty dangerous. So we usually say you want less than 2 nighttime reflux events a month. So pretty strict on that, because if you're having nighttime reflux, how many times are you not waking up?
Mm.
So nighttime reflux is particularly dangerous.
Good to know. Now, if you didn't know, audience, there is a gut-brain connection. Dr. Jones, can you speak on this gut-brain connection and how the two systems can affect one another?
Oh, yes. The gut-brain connection is strong. And so your gut has as many nerves as your entire spinal column. So some people even think it has its own, gut brain, so to say. And then it connects to your brain, and your brain has a mapping of your whole entire GI system. And so if you have depression or you have anxiety, you're going to experience gut pain worse than people that do not have depression and anxiety. In addition, many of our medications for depression and anxiety actually treat abdominal pain by turning down the nervous system and that connection. So we use them all the time, and they're very effective for irritable bowel syndrome.
I was seeing an article that over time, people get more anxiety, and are you seeing it more in your patients, people with higher anxiety levels, and seeing that more brain gut connection?
Yeah, I personally, particularly since COVID, I've seen a lot more depression and anxiety. And so people coming in and presenting with abdominal pain, whether it's lower abdominal pain, cramping with change in bowel habits, which is a description of irritable bowel syndrome, or even just upper stomach pain, which is another type of pain syndrome called functional dyspepsia. But a lot of different pain syndromes are coming through the gut and connected to depression and anxiety.
A sad statistic for sure. Now, Dr. Jones, can you speak to how TPMG Gastroenterology Williamsburg collaborates with other TPMG providers across specialties?
In GI, we collaborate with a lot of different physicians. One of the biggest physicians that I collaborate with is Dr. Lisa Coleman. She's our colorectal surgeon. And so particularly with colon cancer, if I find a cancer or I find a very large high-risk polyp that cannot be removed endoscopically, then she will go in surgically and laparoscopically with her robotic and very high-tech techniques remove it. She's phenomenal. I highly recommend her. I also collaborate with multiple other physician practices in TPMG with my inflammatory bowel disease patients. Some of them can present with eye problems, so I send them to Dr. DeRosa. Some of them have joint problems, so I refer them to TPMG rheumatology. I also send them to TPMG dermatology for their annual skin exams when they're on biologics, and also to gynecology for their female checkups because they're also on biologics. So I work with a lot of TPMG specialists, and of course, working hand in hand with primary care because they're the ones that send me their referrals.
That's a lot of providers. That's exciting.
It is exciting. It's a lot of providers. And so it's great working with them. Sometimes I work with providers not even in GI. Sometimes people come with abdominal pain. We had someone, and their abdominal pain was not a GI organ. They actually had a kidney stone. Oh. So now I'm working with TPMG urology to get them to the right place. So sometimes people come to the wrong place, and I'm trying to help them get to the right place. So that's always still rewarding.
I love that. Yeah. Honestly, I feel like you have one pain that's even remotely close to your stomach. I would think it's abdominal,
Oh, yeah. And so I enjoy it. I had sometimes I work with pain management because people will come in and they have abdominal pain, and I find out it's really not in their abdomen. It's nerve entrapment and the muscle layers, or at an old port site where a nerve got entrapped where it was trying to heal, or sometimes it's floating lower rib pain. And so I'm able to send, and they can get trigger injections to relieve the pain. So that's very rewarding. In gastroenterology, just like pulmonology and most of the ologies, we are internal medicine trained. So we have a very high focus on sick adults. And so, in my internal medicine training, they said the best specialist is a good internist. So focus on being a good internist, and then you'll be a great specialist. And so now as a specialist in GI, my knowledge goes very, very deep in GI, but I still have that broad base to pick up on the things that aren't necessarily in GI because the body, while medicine separates it, because the knowledge is so vast into these different organ systems, they all work together. So in the end, you still have to put it all together.
Now, gastrointestinal health can be a sensitive topic for many. How can we normalize conversations about GI issues and make patients feel more comfortable discussing their symptoms?
How we can, I guess, by talking about it. By this podcast, talking about GI symptoms helps normalize it. But you're right. People are afraid to talk about it, but hopefully they can talk about it to their primary care provider. They can talk about it to me as a physician, because, we deal a lot with fecal incontinence. And that is a topic that people don't want to talk about, but that dramatically affects their life. Having to change clothes, having accidents in the car, being fearful to leave their house. And so, very rewarding when people come in and they have the confidence to tell me about it and we can talk about it and I can fix it. So, again, that's another one I work with Dr. Coleman very closely with. And it's very, very rewarding when people come back in and they've had no episodes.
Do you think that there's a stigma with certain topics like fecal incontinence?
Yeah, absolutely, because no one wants to have it done, and it's just a messy occurrence. So definitely the whole thing is embarrassing for the patient and everyone else around them. But it's important to come in and get checked because one, we want to make sure the structure of your colon's fine. There's not an obstructing lesion that is blocking the stool, and now liquids going around this lesion and leaking out. Okay. Once we make sure the structure's okay, then we're looking at the function. Are things just moving through your colon too fast? And why? Is it a motility problem? Is it something that you're eating? And can we firm up the stool? A lot of times by just finding out why the stool is so loose and then firming it up, 95% maybe of people, their fecal incontinence goes away. So that's exciting. If it still doesn't go away, that's usually when I refer to Dr. Lisa Coleman, and she can do advanced testing, looking at how the anus squeezes, what it looks like, and she even has a device that helps stop and tighten up that anal sphincter. But I'll let her talk about that on another
we'll
podcast.
have to get her on here.
Yes, you'll have to get her on here. She's got some cool tools.
I like that. Now, the field of gastroenterology continues to advance in exciting ways. Are there any emerging trends or ongoing advancements in GI care that you think patients should be aware of?
Oh, yeah. So lots of advances in GI over the past 5 years. So let's take acid reflux, for example. We all are familiar with the proton pump inhibitors. A new medication, Voquenza, has come out, and it works by blocking the pump, but in a different way. So that's really exciting for people that have GERD that has been helped by the PPI, but not enough. Okay, so that GERD advancements are here. In addition, inflammatory bowel disease, if you turn on television, you can't miss the advances. There's a new medication every 2 months, and there's still ongoing research. In fact, I'm still doing research on new medications that are still coming to market. So for those patients that have tried different things and are looking for a study, we do have studies available at TPMG. In addition, colon cancer screening is continuing to occur, and we're continuing to decrease the number of cancers. It's just important to continue to put that out there for people to come and get their colon checked. A lot of people don't want to come out because of the prep, and they're concerned about the procedure, but it's a preventative procedure, and getting colon cancer when you should have been screened is just terrible because it's largely preventable. Don't put your head in the sand. Come on out. I got a gentle prep. Good meds.
I did hear that the colon cancer screening age was lowered.
Yeah, that is true. It is now 45 because people are getting colon cancer at younger ages. So if you see blood in your stool, you need to come see me. You have change in your bowel habits, you need to come see me. But the majority of people that develop colon cancer have no symptoms, which is why we need to check everybody. So I get people all the time saying, why do I need to get my colon checked? No one in my family has cancer. I don't have any symptoms. I'm healthy. I clean eat.
No.
So what? So what? 75% of people that get colon cancer have those same things. And so you don't know because it grows silently inside of you until you get symptoms. And a lot of times then it's a farther stage. We want to catch it when it's a polyp, when it's not even cancer.
Yeah.
And prevent it.
Right. Absolutely.
It's preventable. Now, some people, they get it before the age of 45. That was before the age of screening. But if you're 45 and older, you're not up to date on your screening, you're doing yourself a disservice. Come on out. Tell me what your fears are. We will work with you to get around them.
Wonderful. Medications are always a hot topic, but they're not the only options available for treating GI conditions, are they?
So there are things that you can do to change your gut that don't require medications, okay? Now, you should be evaluated to make sure that you don't have something wrong that needs to be treated. But aside from that, for example, acid reflux, okay? If you Googled acid reflux diet, there's a list of foods that increase acid. Tomatoes, spicy food, anything with acid, orange juice, grapefruit juice, and a lot of chocolate. And a lot of people, these alcohol will worsen their acid reflux. And so by eating, finding those triggers, eliminating those triggers will reduce your acid. Then going that step further, making sure you're, like I mentioned earlier, making sure your stomach's empty, not eating 3 hours before bedtime. So some people will stop eating 3 hours before bedtime, but then they keep drinking fluids. So then they still go to bed laying flat with all this fluid in their belly, and then it comes up and they have heartburn. So cutting out the large amounts of fluids, the eating 3 hours before bedtime so your stomach's empty and small, and then helps prevent nighttime reflux. Raising the head of the bed, sleeping on 2 extra pillows. Now you're adding gravity to it. So instead of laying flat, now it's going to be harder for that reflux to come up because it's going uphill. So these are small little lifestyle, what we call lifestyle changes to help with acid reflux. Same can be said with gas and bloat. A lot of people have a problem with gas and bloat. And again, once you've ruled out problems like celiac disease, infection, you're usually left with air swallowing is the number one cause of gas and bloat. So cutting out carbonated beverages, cutting out the gums, the candies, the straw, people will increase water for their health, but then they're swallowing air every time. So that can get really tricky as far as treatment goes. But then gas bloat can also be related to foods. And so we talk about a lactose-free diet. We talk about a FODMAP diet. So foods as medicine. There's a lot of foods out there that can help or hurt depending on what your symptom is. And the frustrating thing is, it's different for everybody. This person, peanuts makes them have diarrhea. The other person, can't tolerate onions. Onions make them very gassy. So it's basically sometimes having to do a food elimination diet and then slowly adding things back to find out what affects you individually. We do work with dietitians to help as far as nutrition goes. It's more knowing what foods kind of bother people and what to eliminate and then adding them back.
You named all of my favorite stuff.
I'm so
Dr. Jones.
I know.
What's happening?
I hope you don't have gas bloat.
I will say it's getting worse as I get older. I know that's obvious, but yeah, I realize I can't eat the same stuff anymore.
Yeah. Well, it will get worse as you get older. And that's because in your gut, you stop making the enzymes that break down the sugars. So particularly milk and dairy. We have an enzyme called lactase that's made in our GI tract. And as we get older, we stop making it. And that level is different for everybody. It just kind of slowly goes down over time. So we're always eating milk, cheese, yogurt, sour cream, butter, and all of a sudden now for some reason after you eat pizza you feel gassy and you might have looser stools and you don't know why.
Well, research and clinical trials play a crucial role in advancing medical knowledge and delivering breakthrough treatment options to patients. Can you discuss how important clinical studies are in the field of gastrointestinal health?
No study, no medication. That's how they're found. So You do a study on a disease process, and you do it against a placebo, a sugar pill, a fake pill, and then you look to see if it works or if it doesn't. And that's how these medications are discovered and brought to market. So they're very important.
Well, as we wrap up, Dr. Jones, is there one key takeaway you'd like to leave our audience with today?
Colon cancer is preventable. Get your colon checked. If you're having GI issues, talk to your primary care provider, come see us, and then we can make sure that it's not something concerning and then point you in a direction of self-treating as far as foods and lifestyle modifications. A lot of people do come in, with AI, with all the research available at our fingertips. This isn't your grandpa's doctoring anymore. People come in informed and with a lot of information and a lot of misinformation. So I welcome it. I say, come in, tell me what you found so we can see what you're concerned about. Because usually Google always ends in cancer. So usually that's what they're most concerned about, because whatever their symptom ended that. And we can talk about it and we can, approach the problem with actual medical training.
Making sure we don't get that cancer.
That's right. Prevention.
Awesome. Well, thank you so much for your time and valuable insights with us today, Dr. Jones. And to our audience, for more information on gastrointestinal health and to stay updated with TPMG Health Talk, visit mytpmg.com. We look forward to bringing you more valuable health topics in our next episode. Take care.
The information shared on today's podcast is not intended to be medical advice, nor is it meant to replace a professional consultation with a healthcare provider. The opinions expressed in this podcast do not necessarily reflect those of TPMG or its providers and physicians.